In pincer phi, the acetabulum limits the hip range of movement. It could be deep, coxa profunda, or there is a local bony bumper on the acetabulum rim limiting the flexion internal rotation. The retroversion of the acetabulum causes the same situation, but there you have the limited coverage of the posterior acetabulum. The angle usually over 35 degrees and crossover sign is positive. I think that the main issue when you think about rim trimming is to locate your problem. So if the standing AP pelvis X-ray is probably one of the most important studies or imaging preoperatively you have to do. If you see positive posterior wall sign, and there's a red flag as an ischial spine sign, positive, or you have a large os acetabuli causing the pincer FAI situation, I truly recommend that you consider some kind of 3D imaging. The one tool I usually use today is 3D kinematic MRI picture, where we can check the three-dimensional anatomy of the bony structure. We can dilute the acetabulum. Your radiologist can count you the coverage of the acetabulum for the femoral head. And as you can see from the video, you can move this freely. With this case, we see in video, you can see the two quite large os acetabuli fragments, and you can take those fragments away, and you can see what will be the acetabulum coverage after the resection of os acetabuli. And you have to be really careful not to create the DDH situation. With this one, you can move 20 degrees internal rotation of the femur. You can do flexion to 90 degrees, and you can see the impingement which is caused by the bony fragments. Then you can remove those fragments and see what will be the movements of the hip after the resection. If you see these red flags, this white figure of 8 posterior wall sign or ischial spine sign, you should consider rather reverse periacetabular osteotomy than rim trimming. But with this book, you can see for the supplement videos how the resection should go on. If you know that the result of the resection is proper acetabular anatomy, you can go to the video, you can see the landmark, you can see how to do the procedure. In my preference is lateral decubitus position, where you can go without any help of your scrub nurse. I choose to use usually lateral and mid-anterior portals, where I can do the release of the labrum. Then I can do the resection of the acetabulum. You can measure the amount of the resection when you compare it to wideness of the burr blade. You can see how to put the sutures on, and be careful not to tighten those sutures too much so you don't retract your labrum too much, and you can keep the function of the labrum properly. Here we put all suture anchors to the acetabulum. The advance or the benefits of all suture anchors are that you can put those quite near to your joint cartilage, so you don't retract labrum too much. I like to use these suture instruments because you don't pierce too much your labrum. It's very effective to manage the tightness of those sutures, and usually 4 to 5 anchors are enough if you do very deep acetabulum resection. The whole idea, I think, for the hip arthroscopy or hip preserving surgery is that you try to optimize the bony anatomy. So every time you have done the rim resection, you have to take care that the head and neck junction is also compatible for the socket side. And you can see how the flexion goes and labrum moves freely over the femoral head. I do use usually 70 degrees scope and try to be careful not to do too much capsulotomy. If you use large capsulotomies, I do recommend that you also suture the capsule afterwards. So in the end of every chapter, you can see the tips and tricks, how to avoid resection of the rim too much. Labrum is always thin if you do global pincer phi procedure, so be prepared to do also labral reconstruction or augmentation if there is not enough labrum left after your rim resection. And be careful that you don't resect too much and you don't create iatrogenic DDH. The bony correction is the key. Thank you.